Hey everybody, Clay Smith here. Welcome to parklandformula.com. This is a video lecture on special burns. Special burns are those that are electrical, chemical, pediatric, or circumferential. Let's get into it. Electrical burns are considered either high or low voltage, and the arbitrary cutoff is greater than 1,000 is high, less than 1,000 is low. Household voltage is 110 to 120, so it's low. High voltage injuries cause extensive underlying tissue damage because you have the electrical impulse entering, and there's not going to be a lot of surface area burnt on the hand or the foot where the electrical impulse enters. However, all along the pathway where the current has traveled, there will be extensive underlying thermal injury. It literally cooks the tissues as it travels through because bone, muscle, nerve, and vasculature have a much higher resistance than, say, a copper wire. And so as you increase resistance in a circuit, you increase heat. And so you're going to have extensive underlying tissue damage all along the pathway of the electrical impulse. And you're going to be at high risk for, for compartment syndrome, myoglobinuria, etc. In addition, because of the nature of high-voltage electrical injuries, with them causing such violent muscle contraction, you can have associated spine trauma. And a lot of times, these are people that are working on the top of a utility pole, so they might fall and have additional associated blunt trauma. High-voltage electrical injuries are a big problem. Let's look at this once again. Again, you see, I won't say innocuous wounds on the surface, but I will say they don't take up a large total body surface area. Look at the one on the foot in the bottom picture. It's just where the impulse has come in through the upper extremity and literally blown out through the foot. As it travels through the skin is especially high. As it travels out through the skin is especially high resistance. And so you see this this blowout injury through the foot. And everywhere that impulse travels, it's caused damage. Now here we have a child who runs in crying, and the mother says, "My child just ran in crying. I don't know what happened." Well, take a look at the picture. What do you think happened? That's right. This child was gnawing on an electrical cord. And as they got through the insulation of the cord, they received a pop and an arc of electricity, burned the corner of the mouth. Classically speaking, this is one of the low voltage injuries that you might see in the emergency department, especially the pediatric emergency department, this oral commissure type of burn. It's not going to typically be a big problem. However, these are at risk for contractures, so they need to do extensive physical therapy to maintain the mobility of their mouth. And the classic board question that you might get is they could get a delayed bleed from the labial branch of the facial artery. So the labial artery bleed in the oral commissure burn, that's a classic board question you might get. And again, low voltage, less than 1,000 volts. Again, here's a picture. The delayed risk, contractures, and labial artery bleed. This is the history that you'll get for this type of injury. You'll get the history. This man was etching glass. He was using a chemical etching glass. And what do you see? All right, so the chemical is spilled onto the hands. It's spilled onto the leg. What would be the clinical features? First of all, what is this agent? This is hydrofluoric acid. That's the classic acid that is associated with etching glass. That's going to be your board question that you might get. Not only that, it could be the way they present, and they might not know that it's hydrofluoric acid, but you need to know. The clinical features of this, it is extremely painful. This type of burn wound, acid wound, is extremely painful because as hydrofluoric acid penetrates, it begins to form complexes with calcium in the tissues and deposition, and it is extremely aggravating, irritating, painful wound. How do you treat this? Well, the treatment for hydrofluoric acid burn is to use a calcium gluconate 2.5% gel. Your pharmacy will probably have to compound this for you. And a lot of times what our toxicologists will do, if it's a hand burn, they'll literally fill the glove, a non-latex glove, filled with this gel, and have them put their hand in it so that the hand is continuously bathed in this calcium gluconate gel. The risk of this type of injury, especially as you see it splashed over the leg in the lower image, is that they can actually develop hypocalcemia from hydrofluoric acid exposure because of the complexing of this cation by the fluoride ion. Calcium ions can be complexed, taken out of circulation. You get profound hypocalcemia and prolongation of the QT and arrhythmias. So your dispo for these people, most hydrofluoric acid burns are going to be admitted for cardiac monitoring. Let's talk now about chemical burns. First of all, you have to decontaminate. If it's a powder, brush it off. If it's a liquid, wash it off. They need large amounts of tap water. Just irrigate it until the cows come home. If you can, touch the area with a pH strip and follow the pH until it neutralizes to 7. Remember, acids will often cause a coagulative necrosis, whereas alkali cause more of a saponification, and they're going to penetrate more deeply than an acid would. Again, hydrofluoric acid is bad. You treat it with 2.5% calcium gluconate gel. Here's something that you might not know, and something that I've experienced. Petroleum, if it's in contact with the skin for a long period of time, causes burns, just simply by causing cell death, local cell death and cell membrane damage by constant exposure. So if you have a patient that's involved in a motor vehicle crash and they're lying in a pool of gasoline or diesel fuel, this needs to be decontaminated. Simply lying on clothing soaked with gasoline on top of a spine board can cause a full thickness burn. Remember, alkali penetrates more deeply. This is an individual who ingested lye. You see his tongue, you see his pharynx, and here is the endoscopic view of the esophagus. This is not good. Now, on to another form of special burn, pediatric burns. Remember, kids are more afraid, and they're going to be much more apprehensive than an adult who's in the same situation. Because of their large surface area to volume ratio, they're more prone to hypothermia. Their skin is relatively thin compared to an adult, and so with a given thermal injury, they'll have a deeper burn. Scalds are typically the burns you're going to see in kids, and in children, you start the Parkland formula at 10% total body surface area burned, as opposed to adults when you start Parkland fluid resuscitation at 15% total body surface area. And remember, in kids, you add maintenance IV fluid to whatever your Parkland formula calculation is. Watch out, because kids are just hypermetabolic and they will get hypoglycemic on you. The other and probably most important thing about children is they're constantly changing and their body morphology is constant. It's a moving target. So if you have a 1-year-old, their head, as compared to the rest of their body, takes up 18% of the total body surface area. Compare that with, say, a 5-year-old where it's 14%, or an adult where it's 9%. The head is relatively large in relation or in proportion to the rest of the body, and the lower extremities are relatively small in proportion to the rest of the body. This is a fantastic diagram. I recommend you also check out vicburns.org.au. It is a stellar site about taking care of burn patients. When you do estimate the total body surface area for a burned pediatric patient, make sure that you use a chart like this called the Lund-Browder chart. On the Lund-Browder chart, you're going to get a much more accurate estimation of the total body surface area that's involved. It's very easy to either under or overestimate pediatric burn total body surface area unless you use a chart that helps you to sort this out. Now, here is a different kind of burn. Another special burn, Here we have a leg with a circumferential burn. What's the risk of this burn? Yes, this person could absolutely and totally lose their foot because they have a circumferential full thickness burn proximal to their foot. This foot is in danger of necrosis, of losing its blood supply, of developing compartment syndrome downstream. So, let's talk about circumferential burns. You only have to worry about them when the burns are circumferential and they're deep, partial thickness, or full thickness burns. I won't say it can't happen, but it usually doesn't happen with superficial partial thickness burns. It's usually those deeper burns where there's just a lot of loss of elasticity, and it's deep partial thickness and full thickness. And it has to be wrapping whatever limb is involved, 360 degrees around. So you would perform an escharotomy when? Well, we as emergency physicians don't often perform an escharotomy. So you would do this if you were in a situation where there was delayed transport, where the patient was beginning to have symptoms of compartment syndrome with increased pain to passive stretch, or loss of pulses, loss of sensation. You would do it in situations where you had the type of burn listed in point number 1, and you would do it in situations in which there was concern for loss of limb. You also might perform an escharotomy if you find that the chest wall has been burned or the trunk has been burned in a full thickness manner, and it's impeding your ability to bag the patient or to get air in. If their chest is so rigid that your peak pressures are rising, you may have to perform an escharotomy on the trunk. When you do an escharotomy, if you do an escharotomy, I would try to not do an escharotomy. I would try to get them to a burn center, but you may be in a situation where you must. You have to cut through to normal tissue. It doesn't make any difference if you just graze across the burned skin. It has to be deep cuts. So you may have to have electrocautery ready and handy in the event that there's bleeding, because there's going to be bleeding. You also need to do long longitudinal incisions, and I've got a diagram here that I've drawn for you that shows an escharotomy on the chest, arm, leg. All right, so there we've covered 4 types of special burns: electrical, chemical, pediatric burns, and circumferential burns. All right, hope that helps you out. Make sure you go to our website, parklandformula.com. There's a handy Parkland formula calculator and a lot of other stuff that will teach you a bunch about burns. So thanks a lot. Signing off.